So good evening. So today we are here on this platform to show one of the complex case which we have done. That's a Ostial LED chronic total occlusion. So in a patient who underwent primary angioplasty to RCA before, a couple of weeks back. With me is Dr. Damodar,
Good
our
evening.
interventional cardiologist, who is assisting my case, and Dr. Vamshi, who is our interventional fellow, who is assisting our, imaging interpretation, and our nursing and cath lab staff.
So, good evening, everybody. Today, coming to the case, clinical history, it's a 60 years old gentleman, known chronic history of systemic hypertension and chronic diabetic, and he was recently infected with COVID-19 with mild disease and recovered. And he presented to us with ACS NSTEMI with TROP positive. ECG was showing mild ST depression in the inferior leads, and echo was showing RWMA in RCA territory with mild LV dysfunction. His creatinine was 1.02 with eGFR of 82 ml per minute. So we took him for coronary angiogram, and this is a left system. It is showing Ostial LED total occlusion, and LCX is shown very. There is no flow limiting disease in LCX, and this is a culprit vessel RCA showing mid subtotal occlusion. So we went ahead with RCA PTCA and completed with good result. And you can see after completing that RCA, distal LED is filling retrogradely from heterocoronary collaterals from distal RCA. You can see nice septal collaterals filling distal LED. And we attempted LED wiring. So it was not successful, it went into subintimal space. So we abandoned at this moment in view of culprit vessel PTCA. And after one day we discharged the patient, and we asked for a second intervention after 2 weeks, and he came for a second intervention, and today we are attempting this LED PTCA. Anatomicogram, you can see this is a stent in RCA, and the left system you can see Ostial LED total occlusion with ambiguous proximal cap, and CTO appears to be more than 20 mm. It's a long segment CTO. We could not visualize any calcium, and there no much of significant angle in the CTO segment, and distal clap was clear, and since it was a retriation, it scores 1, and total JCTO score counts to 3, and it's a very difficult complex kind of case with JCTO score of 3. Coming to the collaterals, you can see clearly distal PDA is filling retrogradely, it's giving collaterals to the distal LED, and also you could see two epicardial collaterals coming from LCX and proximal RCA.
Yeah. So this is primarily a case of Ostial LED CTO, and we had a discussion in our heart team about different strategies for this patient. So we concluded in our heart team as minimal invasive bypass with the Lima to LED and diagonal grafts as one option, as well as angioplasty, because lesion is limited to Ostial LED, and there is no lesion extension into LM or LCX. As patient preferred percutaneous intervention, so we went ahead with percutaneous intervention. So coming to the strategy, for this patient, so if you look at Ostial LED, so there is a faint filling of ostium, but the problem is there are multiple branches coming out of ostium. So you can see even in our graphic, so there are multiple branches sitting at Ostial LED. So it is quite difficult to understand where the ostium is, so when we are trying to wire. So to wire antegradally this patient, we need a imaging guidance. So my plan is to do an IVUS-guided entry into Ostial LED, and after that, so I do wire escalation if I am sure about my course of wire. But the problem here is, so it's a long segment CTO, and there are two diagonals coming out of LED, probably within the CTO. and we don't have any clarity on the course of the vessel. So most likely we may end up in even retrograde because the length is long and we don't have any clarity on course, at least in angiogram. I feel even dual angiogram shows similar anatomy. So after IVUS-guided entry, so if I'm still not sure with dual injection where my vessel course is, then probably I'll take retrograde and retrograde wiring, and then I'll do a reverse cut in the proximal LAD. So this is where IVUS-guided entry is very, very important. So if you don't do IVUS-guided entry, so it becomes difficult to do reverse cut in this patient, because if your wire comes out in LMCA into true lumen, so then you will end up in closing left circumflex and creating a problem. So that's a whole plan. So IVUS-guided entry, and if antegrade is not progressing, then I'll go retrograde through septal collaterals. Though we have 3 collaterals, the best interventional collateral is septal here. So we'll go to septal collateral and then do reverse cut and then come out and complete the intervention. So that's a plan. So our next 15-20 minutes, we'll show the case. So how it went on. You can see here we have a right French guide coming from femoral sitting in left system, and there is a 7 French JR sitting in right coronary artery, and there is a protection wire placed into the distal RCA. This is very important to secure your retrograde guide position. And yeah, go next. So you can see here, so why I have chosen 8 French guide is basically 8 French guide makes your job of IVUS-guided entry quite easier. So you can use slipstream technique, which makes our job much easier. So you can see here, so we gave a dual injection, and you can see there is little bit of ostium visible and LAD, but there are also coming couple of branches at the same point. So that is our worry. If the wire goes subintimally, if you look at the initial images in post RCA angioplasty where wiring attempt was done, there the wire actually went subintimal. So the chances of wire going subintimal again will be very high in this case. So and as I have to do a good reverse cut if I choose to go retrograde, so I have to be quite sure on my antegrade wiring. So that's why I wanted to choose an IVUS-guided wiring, though there is some ostium visible. So we wired LCX. Yeah, this is epicranial. You can see it's a long CTO, and you can see there are 2 diagonals coming out of CTO. Yeah, and there are good septals which are filling RC LAD. So this is IVUS catheter into the LCX. So just go deep into LCX and then image. So you can see this is the IVUS from LCX. So there is a block in LCX, but you can show the B3, but overall areas are okay. So overall areas are okay. It's more than 4 millimeters square. So our initial decision is not to intervene LCX, only to do ostial LAD. Can you show us ostial LCX size, please? Yeah, so it's more than 5 millimeters square. So that's the reason I didn't want to go with two-stent strategy in this case. So plan is only to do ostial LAD stunting, right? Now I'll go ahead with IVUS-guided wiring. So you can see here my IVUS catheter is deep into OM, and then I advanced a crusade catheter over the same wire into the LCX ostium, and so then we are trying to do antegrade wiring with the Gaia 2 wire. So you can see this is the Gaia 2 wire. So it took a course. You can see where the wire is. So this is how wire entered into subintimal space. You can see here. So that is subintimal, and you can see the lumen of LAD below at 3 o'clock. Please show the lumen at 3 o'clock. Yeah, that's the lumen. So that is where I wanted to enter, but the wire has gone clearly subintimal. So again we rewired, and you can see here, so the wire is just gone subintimal. You can stop actually and show at 1 o'clock there is a bright shadow, not that above. Yeah, see, that is a wire. So that's a wire course. So, and you can see clearly, so lumen is at 4 o'clock, my wire is at 1 o'clock. So you observe the shadow which is coming at 1 o'clock. Yeah, so that clearly subintimal. So that's when I realized, so I think I have to go with a bit stiffer wire. So as I am not able to direct it well, so we shifted wire into Hornet 10. So as Gaia wire is not giving me enough directability, so I shifted to stiffer wire. So that is Hornet 10, and Hornet 10 actually went through the true lumen. I could able to direct it little better. Yeah, so this is a Hornet wire, so which went into the vessel, and here what I am doing is basically I am confirming my wire position through IVUS. See at 3 o'clock, so that's a Hornet wire. So you can see how it is going. You can play now. So it is just going through the lumen. So yeah, you can see, yes, now it is just going through the lumen. So before, the wire was actually going through 1 o'clock subintimal. So now see, we are sure that our wire is in true lumen into LED entry. So this makes our next options more viable and less complicating. So you can see I am pulling my wire on which IVUS catheter is back. So now IVUS catheter is basically out of the wire, right? And then you advance the wire again into the vessel. Yeah, now I am pulling IVUS catheter completely out. So this is a step which is very, very important, because you shouldn't lose the wire position which you have already got. So IVUS is a very short monorail, so you just pull the wire back and then pull the catheter out and advance your wire. So that's how you can bring it out, because the next step is I have to trap wires and remove microcatheter. To trap, I have to send a balloon, and it's not possible to send a balloon when IVUS and Crusade are inside your guide. So that's why you have to remove IVUS without disturbing your antegrade wire. So next what we did is basically trap and remove your Crusade catheter, and then advance Corsair over the antegrade wire. The key is, so this is a trapper balloon. So you can see here, this is the Corsair. So I am advancing Corsair into LED. So whatever position you have got before, you have to secure with your microcatheter. Otherwise, you will end up in doing same steps again and again, and you will lose the battle. So we secured with Corsair into LED. Yeah, so now my Corsair is into LED through my preferred course. So we then immediately we switched wire back to Gaia. So this is very important. We have to de-escalate wire back to Gaia. So don't advance with your Hornet. Hornet is only for entry. So further advancement is with Gaia. So this is Gaia, so which we tried advancing, but clearly what I understood here is the course of the vessel is not clear to me. So where the LED is, so there is diagonal which is filling, but I am not sure about course of the wire. And if you see the wire and probable LED, which we can point out with your diagonal position, they are quite away. You can see here, so you see the they are almost in a different direction. So this is where it's very difficult for antegrade wire advancement further, as I don't know the course. This is when we decided to switch to retrograde, and we have a good interventional septal collateral through PDA which we can try. Yeah, see, we took a guideliner through JR because JR may not support my retrograde microcatheter advancement. So preemptively I kept a guideliner into RCA, and then we took a Caraval. This is a Caraval catheter. So once it is into PDA, we took an injection. You can see there is a loop in the PDA, and there are good septal collaterals downstream which are quite visible. So the second one was quite promising actually, the first and second one after the bend. So we wanted to take that. So because of the bend and PDA, so the wire actually advanced into the septal, which is even proximal to what I wanted to enter, but we thought of just exploring it. Wiring from RCA to LAD is bit difficult when compared to LAD to RCA, and many times you end up in exploring at least a couple of septals for successful wiring. We went deep to the septal, but unfortunately we couldn't reach LAD. There were no PVCs throughout, and we can clearly see here my wire is completely outside LAD. You can clearly see where the LAD is and where the wire is. Then we decided to go ahead with the next sept. You can see there is a clear loop in PDA which is hampering my collateral wiring. So we tried the third septal, then we came back to second septal, and this is where we could cross septal much easily, and you can even see the wire is actually going into the diagonal after entering LAD. And we gave a small injection just to confirm, as the earlier wiring was going in a funny way. So, and the wire movement and injection confirmed wire is in diagonal. Yeah, we went deep into diagonal just to bring some support to advance microcatheter retrogradely next. And slowly we advanced microcatheter. You can see chordside, it's going much easily. There was not much of difficulty in advancing. Yeah, from here I started directing my retrograde wire. This is cyan wire. So, but see, cyan wire was not advancing. You can see that is just buckling at the distal cap, and I have to escalate wiring or take a fielder XTR and explore. So we decided to take a fielder XTR and explore, because that's a wire which normally goes through any microchannel if it is present. So we took a fielder XTR, and you can just see how it is going. Yeah, so it's gone quite well, and now I realized the diagonal which was actually showing as a LAD pointer, that is not the actual course. What fluoroscopy is giving me as a LAD is not ideal. So you can see this is actually the LAD course. My retrograde wire is almost reaching antegrade wire. As I had a doubt about the vessel course, we thought of just injecting retrogradely. As we just went over fielder XTR wire, we thought we are in true lumen, and that's the reason I wanted to inject and see whether two diagonals are coming from LAD or not, so that we can save diagonals flow. So that's when actually everything went on wrong. See here, so my injection created a huge dissection in vessel and also subintimal space. So this is something which shouldn't happen, but it happened on table. Yeah, so from here actually your every step becomes more difficult. Yeah, you can see here, so I shifted wide to Gaia 2 because of the subintimal space. Wides are almost in a different planes. You can see here in epicaudal view, it's completely in a different plane. So we did a 90 degrees view to understand the course of the wires. This is where course of the wires actually looked quite favorable, and they're hugging together in most of the view. So that says we are within the vessel architecture, and also the movement of the both wires is looking like we are within the vessel architecture. But at this point I wanted to confirm where my retrograde wire is. Almost you can see my retrograde wire reached LAD ostium, but it's not coming into the lumen. So we did an IVUS to understand where my wire is. You can see there is a huge subintimal space which I created at LMCA, and that's a wire which is just moving in the subintimal space in LMCA. So the wire actually, yes, this also confirms, wire is within the vessel architecture. And now the challenge is, I have to create a space in Ostial LAD and then do a reverse cut and pull externalized wire and go subsequently. So what we did, so I have sent a balloon, antegrade balloon, I think this is 2 millimeter balloon.
Yes, sir.
So initially I tried with a 2 millimeter balloon, but we couldn't really brought retrograde wire back into true lumen. Then I upgraded a balloon to 3 millimeter balloon, and the retrograde wire here is very important because already I created a huge subintimal space. So you need a very stiff and more directable retrograde wire. So in this case I tried with Gaia 2 and Gaia 3 for reverse cut as a retrograde wire, but it didn't work out. So Hornet 10 actually we directed through the true lumen into LMCA, and then we took a IVUS from LCX to confirm where retrograde wire. You can see there are two wires, one antegrade wire into LID and another is retrograde wire. You can also see the space created by our 3 millimeter balloon. So the two wires are coming into the true lumen. So you can see 10 to 2 o'clock. So there is a huge subintimal space, almost close to adventitia. So there is a huge subintimal space which was created by retrograde wiring. Yeah. So now we came into true lumen. Yes. Yeah. Into guide, and we also confirmed with IVUS, where the wire is in guide or not. You can play this. This is the wire in guide. Yeah. You can see all three wires are in the guide. So that says we are in the guide. Yeah, so this is externalization. So we externalized wire. Next, so after externalization, we took a balloon 2.5 millimeter and then we pre-dilated LED. But what we have to remember here is our wire is through septal and LED is deceased till that septal. So we can't stunt this vessel over retrograde wire. So we have to have an antegrade access into the distal LED before we start stunting this vessel. So we dilated and we created a space there. Next. And another question here is whether my retrograde wire is completely true lumen throughout, or it went to false lumen and came back to true lumen at proximal LED. This is something which is very important because that decides your stunting strategy too. Yeah, so once we dilated, we did IVUS again into the septal wire. So you can see at 4 o'clock, that's a true lumen which is got compressed. We can clearly see IVUS catheter is in the false lumen, and the second diagonal is coming from true lumen, but first diagonal is already collapsed. So we decided to leave it already. We took significant time here, so we thought of leaving first diagonal. Anyway, it is filling quite nicely from OMs nearly TIMI to TIMI 3 flow. So we decided to go ahead with stunting. So regarding stunting strategy, so as this patient had a subintimal hematoma in LMCA, so what is paramount is you have to stunt from Ostial LMCA. So my initial plan was only to stunt from Ostial LAD down, but as I created a subintimal hematoma in LMCA, we decided to go ahead with a stunting from Ostial LMCA. This is the safest strategy for these patients. So never stunt from Ostial LAD. If you stunt from Ostial LAD, you will push subintimal hematoma further proximal and you occlude LMCA. So that's what we decided. So I took a WMN catheter over the retrograde wire and then wired LAD. So as we are sure with IVUS that distal wire, retrograde wire is in true lumen, so we took a WMN catheter and we wired with a workhorse wire. You can see how nicely it is going into distal LAD. So once this is done, we can pull out our retrograde wire. Yeah, we dilated further with 2.5 mm balloon next, and you can see we did IVUS again to understand the entire vessel anatomy and which vessels are coming from true lumen and which vessels I may lose. I think the first diagonal is something which I'm going to lose. So at this stage, before, once you take stunt in, you have to pull the retrograde wire back into septal, and we dilated a 2.75 to 38 mm stunt. So we pulled the retrograde system out. So this is a proximal stunt, which we took, and we are stunting from ostial LMCA. You can also see the subintimal hematoma. We have not injected because we already anticipated this issue, and we did entire thing with only IVUS 3.5 28. So we deployed from ostial LMCA next. So we did a pot with I think 4.25 balloon. So as LMCA was around 4.2, 4.258. So again we are rewiring LCX by using a crusade over the LED wire. So this is important because you won't end up in wiring through struts if you use a WMN catheter. But LCX ostomy is a little bit compressed, probably because of subintimal hematoma. And we can see diagonal is first diagonal, as I already mentioned, we lost it, but rest of the LED is quite good. So then we optimized stunt expansion with balloons. So this is the result we have got after optimization and report, but we were little skeptical about ostial LCX. We did an IVUS again through ostial LCX. So the lumen was around I think 4 mm square, but as there was subintimal hematoma, we are bit concerned, it may progress and it may occlude LCX, so we decided to go ahead with stunting LCX also. So we took a 2.75 38 millimeter, so size according to IVUS, and at this stage the best strategy is you can do a tap. So we have chosen tap. This is 2.7 for 38. So we position, we have deployed, dilated both balloons. So later I optimized again the distal stunt, with a 2.7 for balloon. We went up to almost 28 to 30 atmosphere, and then we did kissing again. So actually we did kissing as we were not comfortable with ostial LCX area. We did kissing with 3 millimeter balloon and 3.5 into LED. So you can see now, so we have a good flow into LED and good flow into LCX, and there is mild contrast extravasation at LMCA, but there's no need to worry because we already stunted across ostial LCX to distal LMCA. So this is a final shot. So this is a final result. So we had a good result, and we can show the IVUS now. The final areas which we have got, you can show me the ostial LCX areas, please. So you can see this is the ostial LCX area 6.1. It was around 5.4 before after first kissing, but when we have chosen 3 millimeter balloon, we have got a good luminal gain of 6.1 mm square. This is LMCA. You can see 15 mm square. So and B3. So this is ostial LED, which is 8.7 mm square. So we have good areas, ostial LED, LCX, and LM areas, and we left it at this juncture. Thank you.